The taxi framework was newly revealed to the world in 2024. This is a framework that has evolved over a few years as I was teaching students how to write measurable and unambiguous goals and trying to explain treatment hierarchies and how clinicians use cues and prompts. In 2023, my colleagues Erin Hopkins and Cassandra Kerr joined me to conduct a research study, which was presented at the Speech and Audiology Canada conference in Vancouver in May 2024. And at the time of recording this, a number of publications and follow-up research studies are underway. Our study had excellent results in improving the clarity and measurability of goals and hierarchies for speech-language pathology. And so I want to share some elements from this framework with you as it takes elements from the ICF and RTSS and creates a very simple process to help you plan your interventions. In this course, I'm applying it to the TBI population, but one of the nice things about the TAXI framework is that it can be used for any population. Now, we haven't tested it outside of the SLP profession yet, but I suspect it will work for many others, and I look forward to our training protocol being replicated for other disciplines. Outcome measures, my favorite. Primary versus secondary measures. When you're training the strategy, your primary measure is always the effectiveness of applying the strategy. So the percentage of steps completed, as we said, 100% is usually the required outcome. But there could be some secondary measures as well. It might be of interest to include something about what happens when he uses the strategy. So with the PQRST example, maybe we could track the speed of completing the task or the accuracy of recall of information read or the percentage of information recalled. So, the main, job number one is learning the strategy, but there are also other aspects that we could measure to demonstrate the sort of side effects, the good results of using the strategy. This table from the Transforming Cognitive Rehab text shows examples of primary and secondary measures across the various stages of intervention. You can see that in the acquisition phase, it's all about knowing and applying the strategy. As mentioned on the previous slide, you might additionally want to monitor the results of using the strategy. But right now, it's all about learning that strategy. As you move into the generalization and maintenance phases, and these phases of training are described in detail in the text, this is where the client is using the strategy across multiple contexts and reporting back to you. You can see here that the measures change to see how often the strategy is used and how effective the client or others feel the strategy is. So the beginning of shifting emphasis from using the strategy to the results of using the strategy. And the last section is called impact data, and those are measures against the aim rather than the target, so very much into the bucket of the outcomes of using the strategy. These often take the form of goal attainment scales or caregiver rating scales, as they are more global measures that relate to the target, but may additionally rely on achievement of other targets, as we discussed in part 2 when we talked about the difference between aims and targets. When we start training a strategy or an external aid, as you'll see in part 6 next, we always provide explicit models. The client needs to see exactly what they need to do. We also always start with massed practice to establish a skill, and then move to distributed practice to consolidate and generalize the skill. We use error minimization approaches together with structured and guided practice. The TAXI framework picks up on this by talking about support hierarchies as the method to minimize errors. Chaining is another important ingredient when teaching a multi-step strategy or multiple steps in using an external aid, like you'll see in part 6. Chaining simply means that you connect the steps together in the correct sequence so that when you finish one, you go to the next practically without thinking. An example would be brushing your teeth. There are many steps involved and you have to do them in the right order. So maybe you wet your toothbrush and then put the toothpaste on, etc. But by chaining those two steps together, you reduce the cognitive load and they become an automatic procedure. So now we come to training discrete facts and routines. These are the sound bites of information that we just need to memorize. A common example is learning a support worker's name or learning your new address or phone number. Maybe you're in school and you need to learn the definition of aphasia. These are all examples of quick facts or concepts that you want to be able to retrieve without thinking. Examples of quick routines might be putting your brakes on before you stand up from your wheelchair, or asking which table to sit at when you enter the dining room. These are all essentially stimulus response situations. You see, hear, or feel this, and so you say or do that. That means they're not usually generalizable. They're usually trained for a very specific purpose. So this chart gives you an overview of some key differences between the three types of training we're talking about. And these differences are really important to think about when deciding how you want to approach meeting a client's need. Should we be using a declarative or a procedural approach for training these little sound bites of information? Most of our moderate to severe TBI clients are going to have weaker declarative memory abilities, so relying on declarative instructional methods like visualization, chunking, etc., probably not going to be the most effective choice. But those declarative teaching methods could be quite successful for someone with a mild TBI. Given that the purpose of this course is to focus on supporting clients with moderate to severe injuries, I'm going to focus this segment on procedural approaches. When you ask the client for their goals, they're probably not going to identify a project. They're going to identify their big picture needs and wants. So, I want to live at home again, I want to go back to work, etc. But once you go through the process of identifying a project, it does become an aim. It's a big, meaningful, concrete product or outcome and requires achievement of multiple targets. And if all goes well, achieving this aim will help the client achieve their even bigger aims. We'll review this again when we go through an example. So a project is sort of like a mini aim, but I would argue that it's also a motivational ingredient. There will be many other ingredients, but the concept of having a meaningful project with a concrete outcome is very motivating for clients. So I think projects are both aims and motivational ingredients. You're thinking, okay, we've got the aim, we've got the ingredients, so what are the targets? And the targets are exactly what we discussed earlier. So using an external aid, using a cognitive strategy, these are the two things that we typically use to support cognition and communication. But then there could be clients with physical and emotional health needs, and they might additionally have strategy and aid use targets relating to the physical and emotional health. And there could be regular targets like you see on the slide, walking on uneven ground, using a slow rate of speech, smiling before asking a question, feeling motivated to engage in therapy. But just remember, the targets are all on support hierarchies. Your task is to track performance on each target with a specified level of support and see if you can fade that support over the course of one or more projects. Let's start with what is not helpful for a patient who's in the PTA stage, post-traumatic amnesia. It's not helpful to be drilling them with questions demanding recall from declarative memory, so orientation quizzing, personal medical history. You're likely to get unreliable information and you're just going to exacerbate frustration and anxiety. No need to be doing confrontation naming, memory games, formal testing. No need to be correcting errors. Instead, you want to prevent errors by using upfront supports and errorless learning approaches. So none of these are terribly helpful in PTA and could actually be counterproductive. And I've linked some articles for you there. So let's talk about some things that are helpful. Here's the first one. Informal assessment or monitoring to determine how best to counsel and educate and when to start more direct interventions. You want to use brief screening tools and otherwise use functional daily activities. And again, check out these references for more detail on that.